No, we'll wait because it's a little early. We got 5 minutes. Oh, here.
You guys, you know?
No, well, it's the meeting. These things when you're just listening, they automatically mute you.
On.
Okay, guys, it is 12:30. So we are going to go ahead and get started. If everyone can hear me okay, this is Ian Borders, maternal fetal medicine physician at North Shore University Health System and the executive director for ILPQC. And I'm so glad that all of you are joining us today for our Promoting Vaginal Birth monthly webinar. We kicked off in December, and we're really excited for this webinar today and think that you guys will get a lot out of our very first webinar together in 2021. So with that, make my slides advance. There we go. So enter for yourself, those in the room, during the webinar in the chat box, your name, role, and institution. And if you're the only on a phone line, just be sure to let us know so we can note your attendance, because we want to make sure that we can get down who's on the call, so we know who is here with us. So we're going to start with just some big picture looks at the Promoting Vaginal Birth Initiative and our baseline data collection, what we've gotten so far. This is the very beginning. With every initiative we do, there is a starting point where we get to look at the very first day of data together, and that's today. When you think about where we've been with other initiatives, hypertension, MNO, a year, 2 years into it, you see all those data points. Today is that very first day of data, so we're excited to share that with you guys. We're also very excited to have Dr. Emily White von Gompel here to talk about the labor culture survey and really just thinking about labor culture and how we're going to be addressing labor culture across this initiative, but really introducing you guys to the labor culture survey that we're going to be using here in Illinois with all of you. And then we're very excited to have Jill Brown, a nurse from the University of Michigan, who's going to be sharing their experience using the labor culture survey in Michigan, and just hear a really, what was it like on the ground for her institution. And then we'll talk a little bit about the nuts and bolts of the details of how we're going to roll out the labor culture survey to all of you. So just to remind you guys where we are in this initiative. If you remember, we're working across a few key drivers that you guys are going to be working on. On the right is different strategies that can be put in place across this initiative to achieve these drivers. So facilitating clinical culture change that promotes and supports vaginal birth is a driver we're really working about today. And if you look at strategy number 2, conduct a labor culture survey to understand current attitudes and beliefs of labor and delivery staff and unit norms. That's the strategy we're going to be talking about today. So, really starting to take a look at how labor culture matters and why it matters on our labor and deliveries. So a reminder about where we stand with our goals together for this initiative. As you guys remember, the overall initiative aim for us together is to have 70% of participating hospitals at or below 24.7% C-section, NTSB C-section delivery rates and that the overall state NTSV C-section rate will be at or below 24.7%. So we'll look to see where that stands now. And then remember the structure measures. These are so important. This is the work that you do where you say red, we haven't started working on it, yellow, we're working on it, and green, hooray, we've implemented this strategy. Filling in your hospital level measures or your structure measures are so important because it helps track where you are in the different system changes that you're working on. And we know that we're working on system changes and culture to get a successful initiative at the end of this 2 years that we're going to be working together. But those structure measures and system changes are really important. So make sure we're paying attention to those well. And then the process measures. In this case, looking at the percentage of providers and nurses who are receiving standardized education regarding our key kind of education components, the ACOG SMFM labor guidelines, labor management strategies, and then those protocols for facilitating decision huddles, decision debriefs, and on patient-centered decision-making. One of the key things we'll be working on are these implementation of the standardized ACOG SMFM criteria around decision-making for cesarean section. And our goal, looking at a random sample of deliveries, will be to look at 80% of cesarean deliveries among NTSV births meeting ACOG SMFM criteria. So that's important regardless of where your hospital sits in terms of your NTSV rate, whether you're too high or just right. Really thinking about how to standardize those ACOG criteria really continues to improve quality and reduces variability between patients. Next slide. Oh, that's mine. So baseline data. Thank you to all the teams who've completed and submitted their baseline data. This is amazing. You guys, 73% of teams have already submitted their patient level data. We have a little bit of catch up to do on the hospital level data. And I think some teams just didn't submit it because they're like, well, we haven't done anything yet. So do I really need to turn in all red for all the structure measures? Yes, 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 yes. It's super important because we need to show progress across time. So you want to show your ability to change across time. So even if you haven't started doing anything yet, and you're answering red, haven't started on your system changes, that's totally fine. That's your starting point. You don't want to wait till you've done everything because then you won't show change. So it's super easy. You just say whether you're red, yellow, or green for each of those system changes. So it doesn't take long to do, but super important to get in. So we can see the baseline, and more important, you can see your baseline across time. Next slide, let's see. So structure measures. This is really important. I just want to remind you guys what these structure measures are that you're going to be working towards. Remember, provider and nurse education on those key components, a standardized protocol for processes for induction, labor support management, and response to labor and fetal heart rate abnormalities, Cesarean decision checklist for ACOG SMFM labor guidelines, decision huddle and/or decision debriefs, workflow process for shared decision-making, standardized patient education promoting vaginal birth strategies, and then a process to review and share data, including provider-level data with clinical teams. So those are some of the key components. We're going to be talking about these structure measures across our different webinars. So you don't have to have these in place. You don't even have to know what these all mean, but important to get your structure measure hospital level data in because it's going to give you that baseline. So what we've all been waiting for, to look at our baseline data. So this is what you guys have submitted so far. Our goal, remember, is to have a C-section, NTSV C-section rate less than 24.7. Our current ILPQC rate is at 27.8. And you see that variability across participating hospitals. Our goal in any quality improvement is to reduce variability. So we're going to be working on this together. It's also important to look at your NTSV C-section rate by race and ethnicity and Medicaid status. We're going to be doing a lot of breaking down data and trying to better understand it for our different patient groups, because we may be really good at our NTSV rate or our induction management with one group and have issues that we didn't realize. It got kind of hidden in the data with another group. So that's why it's going to be so important to look at this data both at the state level, but even more important, look at it at your own hospital's level. So we're going to be asking all of you guys to be looking at your data by race and ethnicity. So Black, white, Hispanic, Asian, other is the way that we're breaking it down. Right now, we see about the same percentage, for example, for Black patients. The overall percent of Black births in Illinois is about 17%, and the overall percent of NTSV NTSB C-sections in Illinois is about 17%. So of the hospitals that submitted data so far, what we're seeing tracks pretty well with the percent of births. But that doesn't mean that that's what it looks like for every individual hospital. And that's why looking at your data by race and ethnicity is so important at the individual hospital level. This is the data looking at it by Medicaid status. So 39.1% of all Illinois births are covered by public insurance, and about 34% of NTSB C-sections are to patients with public insurance. Hospitals with low NTSB C-section rates, we have definitely got this question from folks who are participating in promoting vaginal birth, but may already have a C-section rate less than 24.7. And from looking at that table, we know there's a good number of hospitals that are already at goal for their NTSB C-section rate. There are still a lot of benefits from participating in the PVB initiative. We just want to make sure, as you're working to get buy-in from your providers and your nurses, you have your kind of key things to talk about in terms of why this initiative is so important. So equity, understanding PVB data by race, ethnicity, and Medicaid status, that's something we're going to be talking about. You'll be able to look at through this initiative, and you'll get that data broken down. So that would be very helpful to your hospital and your team. Implement and systematically use the ACOG SMFM guidelines around cesarean decision making. Again, reducing variability and implementing guidelines is something we're going to spend a lot of time talking about. And our data is going to be able to track that and be able to see if there's different groups that meet the guidelines versus those who don't. And so I think that will also be really helpful to teams, regardless of what your baseline NTSB rate is. Identify ways to optimize patient-centered decision-making. This is a really important issue around providing respectful care, listening to patients and having patients feel heard, and really engaging patients in the decision-making process. We're going to be talking a lot to experts from other states who've done this work and be thinking about how we can incorporate some of these strategies here in Illinois. Access to labor management support for nurses and providers. We're going to be doing a lot of labor management support training. And this is something I think that nurses and providers are going to find very valuable. And then learn strategies for continuing sustainability of your success. So let's look at this data quickly so we get to the rest of our awesome talk today. So these are their structure measure. And remember when I said this is day one. So this is when, if you took all those awesome tables that we look at when we can see the data across a year, across 2 years, this is that very first data point, which is when we always label it baseline data all the way over to the left. And here's what this looks like today. So on our first structure measure, implementing provider and nursing education and other strategies to achieve buy-in, you see some teams haven't started working on it. A big chunk of teams are working on this, and some teams have this in place already. So if you're a team who's working on it, we'll continue to support you getting to in place. And if you haven't started working on strategies to get buy-in with your providers and nurses, we would love to talk to you and help you figure out how to do that. Hopefully we'll have some grand round slide sets coming out soon, and really figuring out how to get your team members, your providers and nurses on board. Implementing cesarean decision checklists using ACOG SMFM labor guidelines. So only a smaller group have started working on this. I think this is really appropriate. We haven't talked about this yet, and we haven't kind of delved into our toolkit to figure out how to do this together. So this is coming, and we're going to spend a lot of time talking about this. So I think this is pretty appropriate at this point in the initiative. Same with implementing decision huddles and or decision debriefs with the appropriate care teams to standardize use of those ACOG guidelines and checklists. Again, very appropriate that a big majority of our teams haven't started. That just gives them a nice starting point so they can see that change when they do move into working on it. And we're going to be doing this together on upcoming webinars. Implementing a workflow process to incorporate shared decision-making with patients, a decision huddle, provider, nurse, and patient to review treatment options, risk benefits, and ACOG SMFM guidelines. And again, a few hospitals probably had this in place already, a few are working on it, and most haven't started, which I think is really appropriate for where we are in the initiative. So before I transition over to Emily and hear more about the labor culture survey, I just want to remind you where we are in this process of getting started. We started climbing the stairs of building this PVB initiative launch with each other back at annual conference. Teams got their rosters submitted. You guys reviewed and attended the data call to figure out the data collection. You started having regular PVB team meetings. Hopefully you've reviewed the Promoting Vaginal Birth Key Driver Diagram. If you haven't, it's available online on our toolkit. And you've hopefully looked through the online toolkit with your QI team, which has lots of awesome materials. Almost all of our teams now have conducted their baseline data. If you guys have not done it yet, we are absolutely here to help if you're running into any issues. The most important thing is to get it submitted. We know teams that get their baseline data in and get as a starting point. It's so helpful moving forward. Hopefully you're starting to meet with your QI team and thinking about a 30, 60, 90-day plan, so you know kind of where you're getting started and where you're going. Starting to think about a first PDSA cycle to address your 30, 60, 90-day plan. And number 9 is where we are today, planning a labor culture survey distribution. That's where we are today, and that's what we're going to talk about. So you can see we're really moving through that process of getting started with this PVB initiative, and we're so excited to be welcoming Dr. Emily Van Gompel today to talk about the labor culture survey. Dr. Van Gompel comes to us originally, she was in California with CMQCC, the California Maternal Quality Collaborative, and she did work with them on their Promoting Vaginal Birth initiative and help them and develop this labor culture survey that they used. And the labor culture survey was used with Michigan hospitals as well, which I'm sure she'll tell you about. Dr. Van Gompel, in addition to being an awesome researcher, is a family practice doc and has delivered babies and now works at an FQHC taking care of patients. And we're so excited that she is here in Illinois and actually at North Shore with me, which is amazing. I'm really excited to have Dr. Van Gompel share her work with us today. So Emily, do you want, I'm gonna stop sharing and I'll have you pull up your slides, okay?
Good. And I'm going to share screen too. And then if I do this, hopefully you can see.
Yep, we got it. Take it away.
Are you also seeing the speaker notes or no, just the slide?
Nope, just the
Okay.
slides. You got
Good.
it. Take it
Good.
away.
Okay, so thank you so much, Anne, for that introduction. I think you pretty much covered everything I was going to say. I'll just say I am very honored to also be here presenting to all of you today and just so excited. I'm a Chicagoan native, so you know, all my 5 years in California and working with CMQCC on this work, I'm just so excited to finally see it coming here to Illinois and being able to change where I live and work and where my heart is. So let's get started. So here are my disclosures, and I just definitely want to thank my collaborators, CMQCC, everybody who helped put some of this work together, and then my wonderful collaborators, of which at least one is here today, Jill Brown at the Obstetrics Initiative in Michigan. It's truly been a pleasure to do this work with you all. So these are the concepts I will be covering today. My primary goal with today's presentation is to convince you beyond a shadow of a doubt that culture matters. And specifically, culture matters to achieve your goal of promoting vaginal birth. So we're going to talk about what culture has to do with cesarean, what culture looks like at high-performing hospitals, and then talk about some different ways that culture can shift to be more supportive of vaginal birth. So first off, what is culture and organizational culture? And it has been defined in many different ways. It's the prevailing overall definition suggests that it's the attitudes, beliefs, and subjective norms that exist within an organization to be taught to new members as the correct way to think, feel, and act. This analogy of the iceberg as organizational culture illustrates how some parts of culture are very visible and easily identified. These are things that are usually made visible by organizational leaders. So you'll have our mission statement, our shared values, our structures, our policies. This is the way we say we get things done. And below the surface is an even larger and more massive part of culture, which is the beliefs, perceptions, feelings, norms, all of the unwritten rules and shared assumptions that guide our behaviors on a day-to-day process. So it's before we can fully talk about culture, which is this conglomeration of individual attitudes, we have to talk about the people that make it up. And the specifically providers for right now, though we'll definitely talk about nurses a little bit later as well. So we have huge variation in provider rates, similar to that graph that Anne just showed you about the variation in hospital rates of NTSV C-section rate. Providers showed just the same amount of variation. So what causes this wide provider variation? It's very hard to study fairly, actually. Part of this is this attribution bias, and this is the argument that you'll hear that it's not me, it's them. So physicians in large call pools taking over an already failed labor course, or physicians covering groups that don't do cesarean. It could be selection bias, where my patients are different than their patients. So physicians taking care of patients with different likelihoods of needing a cesarean might have higher cesarean rates. And this is where we get to risk adjusting for patient factors, which the NTSB C-section rate, does take care of pretty significantly. And patients who are more likely to request a cesarean may gravitate towards certain physicians or midwifery groups. So how do you study this fairly? Well, one way is to randomize the patients to providers. So those of you who have access to your chat right now, go ahead and bring that up, because I'm going to ask you to put some things in the chat. So this was a study that had looked at a Southern California hospital that had a 100% laborist model of care. So what this meant is that patients were not assigned to any one provider. When they presented in labor, they got whoever was on shift, on call at that point in time, and everybody was in-house. So you came in, you were there for your entire shift, and then you signed out to the next person. There were 20 different obstetric hospitalists, and they delivered 2,224 NTSB patients. Their cesarean delivery rates varied from 12 to 35%. And so from there, they were able to separate the providers into a high C-section group, the medium C-section group, and the low C-section group. And so if the issue is the patients, you should be able to see some differences. So the patients of the low C-section providers should be lower risk. They should have less complications than the high C-section providers and medium, et cetera. So in your chat, I'm hoping you can just give me an idea which of these variables, which they measured, is different for high C-section providers, medium C-section providers, and low C-section providers. Okay. Induction, race, induction, cervical dilation and admission, cervical dilation, admission, induction. Okay, good. Induction, Bishop score, like that. Okay, so we have kind of the three top ones. You can stop now. Thank you. That was great. So induction was by far the most popular. So let's take a look at this. So in fact, induction, so this is a p-value. To be significant, it needs to be less than 0.05. This is not a significant p-value. So induction is not the answer. Anybody else? So what was the second one? The second one was race. And this also was not significant between the high, medium, and low providers. And then cervical dilation at admission was the other one, and it is also not significant. And then a couple of you that said none of them, and you are correct. That is how this talk usually goes. So there was in fact nothing significantly different about the patients between these three provider groups when you randomized the patients to providers. So that suggests that there's something else going on here. And of course, that's the case, right? We know that there's a lot of different things that go into how providers practice and how they may practice differently. So noting that it's probably multifactorial, for providers within a single hospital or health system, which is where you guys are going to be doing your hard work, most of these are actually the same for everyone, but we still see a ton of variation in provider rates. So where can we look for the difference? If we take away the things that we ought to be able to equalize, we get to concentrate on values and culture and education and training. But this is nebulous, right? Values and culture, which are usually ingrained in our training, are very personal, nebulous, and unmeasurable, right? People have actually measured this. This is a validated survey that was developed actually in British Columbia in Canada, and it looked at many different aspects of provider beliefs. This is one particular scale that came out of it about attitudes towards factors that decrease the cesarean section rate. And it asks providers not whether there's evidence behind these, which there actually is published evidence behind all of these different things, but how they feel about them. And what they found is that individuals' attitudes were associated with their discipline. So specifically, OBs had different attitudes from family medicine physicians, who had different attitudes from nurses, midwives, and doulas. To be clear, this is not about facts or strengths of association. As evidence is generated, we all have filters, and we all have to interpret the evidence and ascribe different levels of importance to it. So this is where we get the confirmation bias. Our personal beliefs impact the credulity and or skepticism with which we will view any new piece of evidence, and whether or not we choose to adopt it and actually integrate it into our practice. So this confirmation bias, which has been taught in Psychology 101 for decades, is making the case of, if we are trying to maximize our patients' chances of having a vaginal birth, we have actually shown that individual providers' attitudes towards evidence-based practices support vaginal birth need to be evidence that is concordant with their beliefs, so that they will actually believe it and actually integrate it into their practice. Using a similar scale in California, we are actually able to show that an individual's C-section rate, so one physician's C-section rate, when looked at through the lens of their attitudes towards birth, individual attitudes towards birth, was significantly associated with their own C-section rate. So what a provider believes affects how they will practice, but it's about more than individual providers. Those of us who practice on labor and delivery units, this should not be a surprise, but it is often hard to show. So this is a study which is a stark reminder of just how impactful experiences impact not just the individual, but the whole unit. So this study looked longitudinally at unscheduled C-section rates, and that's here on the y-axis, on a whole unit relative in time to a catastrophic neonatal outcome, which is depicted here by the dotted line. Here's the baseline rate prior to the event. And what you can see is that the cesarean rate jumps significantly immediately after the event and stays elevated over the next 6 months. This idea that culture is hugely impactful to a woman's C-section risk was central to our ideas in California when we were rolling out the Supporting Vaginal Birth Initiative, which is why CMQCC approached me to create the labor culture survey in the first place. And this is a quote from the head of the Covered California Health Insurance Exchanges, stating, "When a woman goes to a hospital, it's the culture of the hospital that really determines whether or not she gets a cesarean section, not so much her own health." So then it remains to be seen, all right, well, if culture is important, how do we measure this? How do we benchmark hospitals? How do we show whether we're actually changing this aspect of what happens on our unit? So to do this, we went ahead and developed labor culture survey. The goal was to measure a culture supportive of vaginal birth. Using rigorous survey development methods, we created a survey and validated it, and we found it had 6 subscales. 5 of these subscales measure individual attitudes, and the final subscale, this unit microculture, measures perceptions of the culture on your unit, norms, the ways that are correct to act, the things that go unsaid but are deeply ingrained and create what we see, feel, and perceive as normal every single day. So when we looked at these different subscales, these different aspects of unit culture and cesarean delivery rate, what we were able to show is actually that these ones highlighted in yellow were significantly associated with C-section rate by hospital. So what this means, so unit microculture is our unit norms scale. For every 1 point increase in a hospital's agreement that their labor and delivery unit's culture supports vaginal birth, their NTSV C-section rate decreased by a relative 37%. So this is not, you start at NTSV rate of 37%. This is, you take your current NTSV rate and multiply it by 0.37, and that's the amount you decrease before you all go a little bit crazy on me. And similarly, the way we would expect the personal attitude scales to perform, they did. So belief, greater agreement with best practices, those items I showed you before, was associated with an 11% decrease in C-section rate. Fear, so the more personal fear providers and nurses showed towards vaginal birth, C-section rate increased by 4%. And then C-section safety, so overestimating how safe a cesarean is compared with vaginal birth for both babies and mothers, was associated with an increase of 15%. The other thing we did was we looked at hospitals that were already high performing. So hospitals that had NTSV rates of less than 22%. And then we looked at that group sort of as, here's what good culture looks like. Because since this had never been measured before, we needed to be able to benchmark it. And it was very interesting. So there were sort of differences between the patterns between physicians and nurses. And what we found was that for top quartile hospitals, the main ingredients were physicians with these individual attitudes and beliefs that were more supportive of vaginal birth, and nurses that endorsed unit norms that were supportive of vaginal birth. So it was different. It was really about personal attitudes and beliefs for doctors and unit norms and how those were acted out every single day for nurses. So here's an example of a question that we asked that gave us a little bit of an idea that things might be different for doctors and nurses. So you don't have to answer this out loud, but answer this in your head. Do you agree with this statement? Most of my patients have sufficient knowledge about vaginal and cesarean birth to make informed choices. What we found was that nurses and doctors actually had very different assessments of women's knowledge bases for making informed childbirth decisions. This was a bit of a surprise. So the green is our top quartile hospitals, which I described to you before. And they're still, certainly lower than we'd wish for this question, but the physicians and the nurses were more on the same page. They were closer together. However, at the lower performing hospitals, physicians were significantly in greater agreement than their nurses that they were practicing beside. And so this discordance pattern, where the distance in attitudes between doctors and nurses was larger at underperforming hospitals, was actually seen for 4 out of 6 of the labor culture scales when we looked at this more holistically. All right. So what I've just described to you is culture at baseline. And we found that culture at baseline predicts cesarean rate. But what we're interested in, the whole reason that we're here, is we want to change our cesarean rate. We want to be able to move the needle. So what do we need to do to facilitate change? So in order to answer this, we looked at the 55 hospitals across California that had been participating in the Cesarean Collaborative and completed both the labor culture survey and were in waves 1 and 2 of their supporting vaginal birth initiative. We looked at the quantitative data for all 55 of these hospitals, and our successful hospitals, those that actually changed their C-section rate by at least 5 percentage points or achieved the Healthy People 2020 goal, are in this red color. Ones that didn't achieve that goal are in the cyan. From those 55, we then chose 8 to do semi-structured interviews with their leads, their clinical lead champions, physicians and nurses who were in charge of leading the Supporting Vaginal Birth initiative at their hospital. And you can see again, here was our sample. Quantitatively, what we found was there was really not all that much difference in our hospitals that changed their C-section rate and didn't change their C-section rate. There was really no difference in hospital level geography, delivery volume, nursery acuity, or their maternal characteristics. What was different was the individuals that were responding to the survey. There was a greater variety of respondent disciplines, so a little bit more engagement in terms of the CNMs, the family medicine docs, anesthesia, and the nurse managers. Additionally, we also found that physicians and midwives that had been in practice at successful hospitals had been in practice for less time. So 15.9 years median versus 20.3 years. All right, so which factors best predicted success? So surprise, surprise again, physician attitude. So here's our unsuccessful hospitals, which we're gonna call non-responder. And then our successful hospitals here. These are the physician response, these are the means on each of these scales, and here are the nurse responses. And so once again, we see that physician individual attitudes are significantly different at hospitals that were successful in changing their NTSV rates compared with the non-responder hospitals. And for nurses, their individual attitudes, if you just look at the means here, are almost universally more supportive of vaginal birth than their physician counterparts. However, at successful hospitals, the nurses are perceiving these unit norms are more supportive of vaginal birth. And remember, these are hospitals that all started above goal. All of them needed to change, and some of them did, and some of them did not. This is an example. These are examples from the best practices scale of things that were significantly different, mainly for our physicians. These are percent agreement numbers here. And just an example of this, providing more midwifery services, whether or not you agree that this is a good strategy to reduce your C-section rate. Nurses, by and large, were in agreement with this about 2/3 of the time, both at successful and non-responder hospitals. Physicians, on the other hand, showed almost double the agreement at successful hospitals versus non-responder hospitals. Similarly, implementing a program that supports sorry, could you mute, please? Everybody mute. Implementing a program that supports early labor at home. Same thing, physicians were 76% in agreement with this versus at unsuccessful hospital, 57%. Providing more doula services, reducing the number of inductions of labor for non-medical reasons. So now I want to take you through some of our key informant interviews. We did thematic analysis on these. So after we got all of the interview transcripts, we looked through to try and find what are the common themes that people are saying over and over, and how are they related to the successful hospitals versus the non-responder hospitals. So the first theme, and this came out over and over again, was really about nurse-physician relationships. And they were described as functional or dysfunctional in several different ways. Nurses stated that longer practicing physicians were resistant to being told that they were wrong. Newer physicians tended to be more open to collaborative practice. And this was intertwined with functional and dysfunctional communication themes throughout. Here's an example of an RNMD relationship quote illustrating this collaborative versus hierarchical style. A lot of these new physicians coming in listen to the nurses now. They have a better relationship. They know that the nurses are the ones at the bedside. It's not so much, I'm the doctor, you're going to do everything that I'm telling you to do. It's a different culture with physicians coming out of med school now. This is a way that nurse-physician relationships talked about communication. So how do you use communication? Is it open? Is it closed? Is it direct? Is it indirect? Here's an example of a physician from a successful hospital talking about communication. It's often centered around some discrepancy in management, where I want the nurse to do something and she says, I can't, that's not protocol or that's not policy. Instead of discarding that, I try to get a larger picture. We dive into the discrepancy. It's just a larger discussion. Now contrast that with this, a physician from a non-responder hospital is talking about their communication around C-section rates. Oh, we just talk about the section rate and how it's the goal of the hospital to get it down. I mean, nobody goes straight out at someone and says it's because of you or you. You know, we try to be as politically correct and still try to get the message across. The second theme I wanted to share with you was about shared knowledge about best practices. Shared access to information and knowledge across the entire unit was key in terms of how the L&D units leveraged best practices in their day-to-day communications and decision-making. So when you do interprofessional education and everybody's on the same page, everybody has the same baseline understanding and expectations, and they know the evidence at the same level, nobody can one-up anybody, right? So you can't have an interaction where you have two people talking about some sort of privileged information that the other person doesn't know. So this is an example of a nurse commenting on that. We did a lot of joint education with with the providers and the nurses. We've been pulling the providers in. We conducted a unit retreat about a year ago. This was our surprise theme. So cultural flexibility came out kind of out of nowhere, though I suppose we should have foreseen it. Participants characterized this as a culture that accommodates and respects subcultures. So leadership not only acknowledges that subcultures exist, but leverages them. So when we're making, this is a charge nurse talking, when we're making the assignment, we take different things into consideration. If there's someone who has a natural approach, well, so-and-so is going to be great for this patient because that's how she likes to practice. The nurse then feels rewarded because they're having the type of experience that is in alignment with their beliefs as well. So it's not just saying, yes, we know subcultures exist. Yes, we know this is there and fine, they can do their thing, but it's actually taking it and using it. Okay, so the last thing I want to leave you with is the potential risks of leaving culture out of our efforts to promote vaginal birth. So after 1 year of implementation in Maryland's initiative to reduce cesarean, researchers found the readiness domain, which includes developing a culture that values vaginal birth and promotes use of shared decision-making and patient-centered care, was actually the most likely to be left out. Hospitals reported that they had not implemented this more than any other part of the toolkit. And if they had implemented it, primarily all they had done was create a team to do something about it. If we fail to address culture, our efforts are likely to fail in the long run with rebounding cesarean rates, and that has been seen in California to a certain extent. However, I want to highlight an even more potentially dire consequence. So Black birthing people have cesareans at higher rates than their white counterparts. Shared decision-making is one of the only things that has been found in studies to reduce cesareans in Black birthing people. So if we leave culture out of our implementation efforts, we risk making these disparities worse. So hopefully, I have convinced you, beyond a shadow of a doubt, to incorporate culture early, often, and throughout your the Promoting Vaginal Birth initiative. So that's all. Thank you.
Thank you, Emily. Okay, I will share my screen. Do you want to stop sharing?
Yep. Let me figure out how to do that.
Just hover on the top. You should see a stop sharing.
Yeah, I'm just trying to find my Zoom. There we go. Okay.
Okay, let me go back. Okay. Wonderful. Well, Emily, thank you so much. I think that gave everyone, our goal was to give you guys this big perspective of why culture matters so much and why folks are making such a big deal of that and why the hospitals in California doing this work really found how important it was, why it's been implemented in Michigan, and why we're going to be implementing the labor culture survey with you all so that you get detailed reports that really look to the culture on your unit so that you can use that data to really drive improvement. So with that, I'd like to introduce Jill Brown. Jill, are you there? Can you come off mute?
Hi, yes, I'm here.
Hi, Jill. How are you today?
How are you?
Good. We're so glad to have you from Michigan. Are you guys going to get this snowstorm today that we are?
Yes, we are bracing for it.
Yeah, we are too. Okay, well, everyone will have to stay safe out there. Luckily, we're all snug somewhere, hopefully. Okay, I'm going to turn the floor over to you. We're so excited to hear about how you put this into action using Dr. Van Gompel's labor culture survey in Michigan.
Great.
Do you want me to keep going or just tell me when?
Okay, sorry. Yeah, just stay right there. So yes, my name is Jill Brown. I'm a clinical quality nurse for the Obstetrics Initiative here in Michigan. So thank you for having us, and thank you to Dr. Van Gompel. I always learn so much when I listen to her speak. Next slide, please. So my goal for this talk is to kind of take all the great information that Dr. Van Gompel just gave you and translate that to the hospital level. And to also kind of talk to you a little bit about how hospitals are using the results of their survey to affect change at their site. I work for the Obstetrics Initiative in Michigan, and the Obstetrics Initiative is a data-driven quality improvement collaborative working to support vaginal birth and safely reduce the use of cesarean delivery among low-risk birthing people in Michigan. Currently, we have 74 hospitals engaged in our efforts. Next slide, please. Just a quick disclosure that we are funded by Blue Cross Blue Shield of Michigan. Next slide, please. And just as a brief background, we learned about the culture survey from one of our member hospitals who had recently collaborated with Dr. Van Gompel on delivering the survey to their staff. And so we decided we wanted to offer this opportunity to our entire collaborative. So much like you're doing today, we invited Dr. Van Gompel to present at our November 2019 semi-annual meeting. And here she is, a picture of her speaking on that day when we could all be together. So we miss those days. And so she was a valuable asset to us to build excitement for this project, and supported us throughout our implementation and analysis process. Next slide, please. As far as survey implementation, we divided interested hospitals into 4 cohorts and allowed them to choose a 3-week participation window between February and May 2020. Despite the slight disruption of a global pandemic, we had over 3,000 maternity care professionals from 57 OBI participating sites respond to the survey. Of the respondent hospitals, the majority were teaching hospitals in urban settings and also have a NICU. 56 out of the 57 sites were able to achieve a greater than 50% response rate. Next slide. This is an example of the first round, the individual hospital reports that we sent out after just a few weeks after each site participated. These can be a little overwhelming to look at, but it's really helpful to kind of hear somebody walk through a report, which Dr. Van Gompel was a very wonderful resource for us for that too. So taking a look at this example here, let me just back up just for a second here. Keeping in mind when you look at your report, you want to look for areas of high discordance among staffing categories, and then also areas of high agreement. So for example, in this top question, you can see that physicians perceive that their patients are sufficiently prepared for labor and birth, while nurses and midwives in this question scored a little bit lower. And just like Dr. Van Gompel alluded to in her presentation, this was a fairly common finding among our hospitals as well, and highlighted some of the disagreement between what patients may be, the education they may be receiving prenatally, and then what's actually translating to the hospital setting. So this may be an opportunity to reevaluate prenatal education delivery and getting patient feedback at this site. So conversely, it's also helpful to look at areas of high agreement when choosing response activity. So the second example here, you can see that all the staffing categories, the nurses, physicians, and midwives agree that improving patient preparation for labor and birth is a useful activity. So this may be a good project for this hospital to select. Wanted to pass on a little pearl of wisdom. So kind of if you take nothing else away from this presentation, something that Dr. Van Gompel shared with us, I think is important to pass on to you guys as well. That when you're thinking about selecting an activity, this isn't a one-person, a team of one process. You really want to take your report to your team and together and really ask them what stands out to them on their report. Why do they think some of these variances exist? And then involve them early on selecting a response activity, because culture change isn't something that you want to get buy-in for. It won't work if people think you're selling something. You want to make improvement. You're making an improvement to the environment that they work in and deliver patient care in. So this change really needs to feel organic and unique to your organization. Next slide, please. So after completion of the collaborative-wide analysis over the summer, we sent out a second round of reports to each site. And these reports were instrumental in helping answer everyone's burning question is, that's great, my results are great, but how do I compare to the top performing hospitals around the state? And then this round of reporting also allowed us to highlight the key themes from our Michigan sample that were shown to have significant impact on reducing the primary cesarean rate in Michigan. Next slide. Oh, next slide, please.
Sorry.
Okay, that's okay. Each report included a definition of what comprises a top performing hospital among OBI participating hospitals and helped establish a benchmark for our hospitals to aim for. Next slide. The comparison reports, as with the individual reports, again, you want to focus on areas of high agreement and high discordance, but with the added layer of how top performing sites score and the same response. So in the top example here, you can see that 21.4% of physicians at the individual hospital believe that cesarean birth rate is safer for the baby than vaginal birth. This is quite a bit different than the 10.6 at the top performing sites. So this is likely an area of opportunity for this site. And an example response activity could be to invite a national speaker who's or hold a grand rounds presentation and present a journal that supports neonatal birth outcomes literature. In the bottom example, sorry, one more to go there on that slide. In the bottom example, the question is, how strongly do you agree with the culture of my labor and delivery unit supports vaginal birth and discourages the overuse of cesarean sections? You can see that the difference in this response in the all staff category as compared to the top performers is quite different. And then as you look across each staffing category, that kind of helps you take a deeper dive into where some of that discordance is really surfacing. So this would be a great question to present to the maternity care team to hear what their thoughts are as a whole and why these differences exist. Okay, next slide. So there are several resources available for selecting a survey response activity. And this is one of them here, the CMQCC implementation guide. It's quite comprehensive and available through the CMQCC website, as well as we have it linked on our OBI website. Next slide. And then based on the results of our collaborative-wide analysis, we learned the key areas for change in Michigan were physician supervision, safety culture, and unit microculture subscales. So we created a customized guide that focused on these areas for our hospitals. And your coordinating center staff have assembled similar resources on the ILPQC website and will be available to help support you as your results come in as well. Next slide. So the next steps for our sites, the 2020 participants are currently selecting a culture change activity, and then we'll work on that this year and repeat the survey in 2022. And we'll be able to compare their results. And then the 2021, we're offering the survey again just for some sites who weren't able to do it last year as sort of a catch up. So just stay tuned and maybe check back with us next year, and we can maybe get some hospital sites that have really been able to make some change in this area, let you know how it went and what they did. So please let me know what questions you have. Feel free to email me, and thank you so much.
Jill, would you be okay if people have questions, why don't you guys put them in the chat, and then Jill, can you meet people in the chat box while I want to make sure we get to present the nuts and bolts of how these the teams are going to be accessing the labor culture survey that we're making available for them soon. So if you guys have chat questions for Jill specifically, some of those questions might get answered in what we're talking about next. But feel free to ask Jill. And if not, Jill, are you okay with people emailing you with specific questions?
Yes, absolutely.
Okay, guys, and you see her contact information here, or we can help you get in touch with Jill, or if you're interested in talking with more hospitals in Michigan as examples. So with that, what I'd love to do, I think that Jill and Emily gave us a great introduction to why we're engaging in the labor culture survey as we get started on this Promoting Vaginal Birth initiative together. I think you guys remember when we were hearing from Dr. LaGrue back in, was that at the annual conference? I think so. He talked about, that changing culture is one of those, it's not the walk in the park or the small hills, it's one of those kind of climbing the mountain. And we're starting it early. Often we start with the easiest things to do, but we're starting this early because it's something we want you to take the long view approach to, and having this information early is going to really help you see places and ideas that you can really pay attention to as you're working on this initiative. So we don't expect you to do the labor culture survey and then have one of your very first things you do on this initiative be to change the culture. We expect using the survey so that you can get a baseline of where you're starting at. It can give you ideas of where your institution might have opportunities for improvement. And you can use that for that kind of long view culture change. So this is really starting, I think we often work hard the first year really just on systems changes and think about culture, something that we're going to work on the second year of the initiative. But I think this is a really helpful starting point just to get a baseline of where you stand on culture on your unit. And so that's why we're doing it in this order this time. So let me talk to you about how you guys will get access to the labor culture survey. So we will be providing the survey to all participating PVB hospital teams. The survey will be provided through ILPQC using REDCap. We don't have it quite ready to go yet because there's some things in the background we have to continue to suss out before we can release it to everyone. But we are expecting the REDCap access to the survey will be available late February, but that's okay because there are some things we want you guys to do to get ready before you're ready to access the survey. Clinical staff will use a drop-down option and choose your hospital name, your same name that's currently in REDCap, and that's how you'll access it. ILPQC has also created materials to assist QI teams in launching your survey. So we have materials like your draft email to send out to providers and nurses and clinical staff, a follow-up email to send to providers and nurses, a flyer with a QR code that they can just scan and look at. So we have lots of things that are going to help you guys do this efficiently and effectively. So we do want you to complete the ILPQC Labor Culture Survey Inquiry Form right now. That is a 2-minute REDCap survey that will help ILPQC share your weekly progress and results. So this is helping you get started on the process of being able to do the survey. So just complete the inquiry form. That basically says that you want to do the labor culture survey and get you plugged into having access. So if everyone can do that as soon as possible, you can do it right when we get off the call today, but just you're gonna want to complete that inquiry form. It's very short and it's just a little bit of information from you, and that will allow you to get started in the process of us giving you access to the labor culture survey for your institution. Meet with your QI team to discuss the following regarding the survey. Who do you need to involve in the process? Who do you need to obtain buy-in from? Do you want to obtain buy-in from administration or obstetric leaders, nursing leaders? Which QI team members will be responsible for the various action steps? And how you distribute the survey, and where will you post flyers to get providers, nurses, and clinical staff excited about completing the survey. Obtaining buy-in and forming an administration. We have ILPQC Labor Culture Survey resources that we're going to share with you guys, draft letters, emails, etc., that will give you the tools so you don't have to come up with something on your own. Of course, you can always do it on your own. You can always revise it, but this gives you a starting point. After the ILPQC survey link is received by you all, again, this will be sometime in late February is what we're estimating. You will share it with staff by emailing all clinical staff using the ILPQC Labor Culture Survey launch email language that you can revise, and then also by posting the Labor Culture Survey flyers around labor and delivery so people can just scan them on their phone, get the QR code, and do it automatically. So the inquiry form, this is the first step in launching your hospital's labor culture survey. All promoting vaginal birth participating hospitals should complete and submit this by February 8th. So that's the deadline to get this inquiry form into us. And again, that helps us get ready to send you and get you access to the labor culture survey. This isn't taking the labor culture survey. This is the inquiry form that sets your institution up to participate. It's really easy to do. Just fill in some information about your institution and get that into us by February 8th. You'll need to designate a labor culture survey point person who will receive the REDCap survey link and the weekly reports that you're going to be getting to share with your institution. And then just fill it out to the best of your knowledge, and please contact us if you have any questions. So in terms of those resources I was talking about, this is just as always, we're trying to make it as easy for you guys as possible to do this work with the least amount of effort. So we have an administrative buy-in email. This is just sample language for teams to share with administration to assist them with buy-in, get them to know what the labor culture survey is and how it's going to be used, and potentially help with labor culture survey distribution. Number 2, we have a labor culture launch email. This is an explanation of labor culture survey and instructions that can be used for all clinical staff. We have a labor culture survey follow-up email number 1. This can be sent out or personalized to assist with getting it completed. And then a follow-up email number 2 that you kind of use right before you're closing the survey down that can be personalized to share your breakdown of how many nurses, how many providers have participated with your goal of getting to 100% participation and who's left to complete the survey. Once you fill out your inquiry form, then we will send you these designated, these resources to the designated point person. This is the labor culture survey flyer that we told you about. Contains a QR code for easy access to labor culture survey for all staff. You're going to post the labor culture survey around your unit in break rooms, bathrooms, nurses stations, physician workrooms, etc. And then all they have to do is scan the survey, choose their hospital from the drop-down menu, answer their questions, and submit it. So super, super easy to get this done. And hopefully with the goal of getting 100% participation across your providers and your nurses. So next steps. Fill our labor culture inquiry form on REDCap. Remember, we need that by February 8th. Super easy to do, and that's what gets you started getting the information you need to do the labor culture survey at your institution. Make sure to get your baseline data collection in. If you haven't done your hospital level data collection, remember that's just those structure measures, the systems change, red if you've completed it, yellow working on it, green, you got it implemented. It's okay if every one of your structure measures are red. That's a perfectly fine starting place. And we just need you to get that in so you have a starting place to compare. Otherwise you won't have a comparison that will really show you making that improvement. So please get all your baseline data in. If you have any issues with baseline data collection, please contact us. So important that everyone gets that submitted. We are going to begin our monthly data collection. So for January 2021, this will be due February 15th. And then we'll be able to compare that to baseline. If you have any questions about the monthly data collection, please contact our team. Make sure to add ILPQC to your safe sender list so that you're getting all of our emails. Register for the monthly webinars now that they're on Zoom. You can add them to your calendar so that they're right there. And then be thinking about some sort of brand rounds or OB provider meeting or some other buy-in kickoff event for your institution to really start talking about the Promoting Vaginal Birth Initiative and what this is going to look like. Maybe you want to do it around the time you launch the labor culture survey, but thinking about how to get buy-in so folks understand what the initiative is going to be about and what the different components you're going to be working on together is a great idea. We are working on a grand rounds slide set right now, and we'll let all of you know when that slide set is available. If you have any questions, email at us info@ilpqc.org, or you can email Ellie Seuss, the coordinator who's helping to lead the Promoting Vaginal Birth Initiative. So either the info account or Ellie's email is a great way to reach us. And then for upcoming monthly webinars, we will be meeting together on Monday, February 22nd, again, 12:30 to 1:30. The Zoom registration link should be available on the ilpqc.org. This one is going to be about creating buy-in and overcoming resistance to change. So a great kickoff to think about if you're planning a buy-in or a kickoff call. In March, like I promised, we're going to be spending a lot of time talking about ACOG SMFM guidelines, implementing a checklist and other systems changes to really think about how we're going to be incorporating those guidelines into labor and delivery and using them in a standardized way with every patient. And then in April, something I think we're all excited about, we're going to start the process of talking about labor management support and the kind of trainings that are available for nurses and for providers. And then in May, we will have our virtual face-to-face meeting and really start to break down and get in the weeds and hear about the progress people are making, how they're getting started, and really spend that time learning from each other. Okay, guys, I don't know that we have time for questions, and hopefully folks have been putting questions into the chat for Jill or for Emily. If you have questions for us that we did not get to today, you can put them in the chat right now and we'll follow up with you. And I'll stay on the line a little bit. Or you can email us at info@ilpqc.org or at Ellie's. Ellie or Autumn, are there questions in the chat that you have been seeing that we should answer directly since more people are asking them?
No, I don't think we've gotten any questions.
Okay. I'm going to just stand for a minute. If there are burning questions that folks have, please let us know. We want to make sure that you guys feel supported and you really understand the process. I think the good news for Labor Culture Survey is right now, all you have to do is fill out the inquiry form and get excited to do this work at your institution. And then, you know, in about over the next month, once we get all the inquiry forms in, get the documents out to everyone, we'll be ready to roll out the Labor Culture Survey. We want to give you all some time to kind of prepare, start to think about what you're going to do for buy-in and the process you want to do for getting this Labor Culture Survey up and going. And in the meantime, you can make sure you're focused on getting your baseline data in and getting started with that monthly data collection. So not to do too much at once as we're getting this initiative started together. Hopefully
Hey, Ann,
everyone, yes.
we did have a question from Mary Jarvis. She asked, do we need to put each individual NTSV data from form in the red caps? Mary, I'm not sure if I understand your question, so maybe you can just take that offline and like email me, because I'm not sure if I understand.
Yeah, I think she's getting at, Mary, or you can come offline. I think you're saying like how to upload your baseline data, is that right? Well, or you guys can, if Mary can't come off mute, we can have her just follow up with Autumn directly, and then we can share that question as well. If it's not clear to folks, we could share that.
I'm off mute. Can you hear me?
Yeah, hi Mary, can you
Hi.
ask your question?
So I have each individual, so for the October, November, and December data, does each individual sheet have to go into red caps in addition to the baseline data?
So the baseline data is the October, November, and December.
Right, and there's two different, in red caps, there's two different categories in red caps. One is where you put in the data for the individual sheets.
The patient level data?
Yeah, and then there is one where you put the hospital data, like the cumulative data.
The hospital level data is your structure measures, and then also probably, I don't know, the you've got
It's
NTSV.
cumulative.
Yeah. So the NTSV, those are three different kinds of data. So you've got your patient level data is where you're collecting your samples of C-section or vaginal births and reporting on them based on ACOG guidelines. That's your patient level data. Your hospital level data is where you answer that red, yellow, green for your systems changes, your structure.
Right.
And then also the NTSV is your overall NTSV rate for your hospital. So that's separate. That's your hospital's NTSV C-section rate. Does that make sense?
Mary, go ahead and you've got my cell phone number. Give me a call and I'll explain it.
Okay.
Yeah, so it's
All
basically patient level data is where you look at the ACOG, those samples charts that you pulled for C-sections, vaginal deliveries, and look at the ACOG guidelines. That goes into patient level data, hospital level data, system changes, and then your hospital's overall NTSV C-section rate, like you'd be tracking at the hospital level.
Okay.
Does that hopefully it makes sense? And then call Autumn on her cell, and she's gonna make it all clear if there's anything we didn't make clear.
Okay.
Okay,
Right.
guys.
Thanks.
We're going to wrap up. So please save the date for the face-to-face meeting. The OB teams will be in May. Neonatal teams, May 27th, OB on May 26th. And then I think we've shared this already, but the annual conference will be October 28th this year. So thanks you guys for another wonderful, wonderful webinar. I'm really appreciative of our two speakers. Dr. Emily Van Gompel, and our lovely talk from Michigan from Jill. We really appreciate you guys being on, and we're very excited about launching this labor culture work with all of you.
Yeah,
Please let
and
us know how we can be helpful. Yes, Autumn?
oh, just one last thing. So people are asking about when, how they complete the survey inquiry form. We're going to send it out in the newsletter. So look for the link to the inquiry form in your newsletter.
And
Okay,
I'll also
yes.
put it on the website so that
Perfect, Allie.
there as well.
Okay, so Ellie is saying that the inquiry form, I should have mentioned this, sorry guys, that was my fault. The inquiry form will be on the website, ilpqc.org, and it's going to come out in your newsletter. So you'll have access to it in 2 places. Sorry, that was not clear. Okay, thanks guys. We'll talk to you soon. Everyone stay safe out there. Bye-bye.